Now continuing with our look at ear embryology, let's focus on the meatal plug and pinna formation. We're about to see how a simple fold becomes a complex canal and, how 6 tiny little bumps assemble themselves into the intricate shape of the outer ear.
All right, let's dive right in, starting with the very foundation. Before there's anything that looks like an ear, there's just this simple little groove on the embryo surface. This is ground zero, the exact spot where the future channel for sound is going to be carved out.
So, everything, and I mean everything, begins with this structure right here, the first branchial groove. It's basically just an indentation of the surface layer of cells, the ectoderm, and it's nestled right between the first and second branchial arches. And if you remember, those are the fundamental building blocks for the face and neck. So you can think of this groove as the first line drawn on the blueprint, marking the exact location for the ear canal. Now, this process is just remarkably precise. The groove starts to deepen, pushing inward, almost like it's tunneling, until it meets tissue that's developing from the inside. That's the first pharyngeal pouch. And that point of contact where they meet, that specific zone is destined to become the eardrum itself, with the groove's ectoderm forming its absolutely critical outer layer.
Okay, and now we get to a part of the process that seems, well, kind of strange. After carefully building this canal, the body immediately fills it back in. I know, it sounds like a major design flaw, right? But it's actually one of the most critical phases in the whole development.
So this really begs the question, what is the biological point of this meatal plug? Why go through all the trouble of digging a tunnel just to wall it up with a solid core of cells for several months? It seems so counterintuitive.
Well, here's the high-stakes trade-off. On one hand, that plug acts like a temporary scaffold. It's a protective shield for the super delicate 3-layered eardrum that's forming just behind it. But, and this is a big but, there's a serious risk. If this plug doesn't get the signal to dissolve and just disappear by the 28th week, the canal stays blocked. This leads to a condition called congenital canal atresia. And this is not just some theoretical risk we talk about in textbooks. This failure of canalization happens in about 1 in every 10,000 to 20,000 births, and it causes a significant conductive hearing loss right from day one. That makes this temporary biological wall a step with just profound clinical importance. So while all this drama with the canal being walled off is happening on the inside, there's this beautiful piece of biological sculpture happening right next door. The pinna, the part of the ear we can actually see, is being assembled from scratch. It's pretty incredible. The entire intricate shape of your outer ear, all of its folds and curves, is formed from the fusion of 6 small bumps of tissue. These are called the hillocks of His. And these 6 little modules, they pop up right on the edges of that same first branchial groove we started with. The first 3 hillocks, which come from the first branchial arch, are responsible for the front and top parts of the ear. So, hillock 1 becomes the tragus, that little flap you can press on. And then hillocks 2 and 3 fuse together to form the main outer rim, which we call the helix. Then you've got the other 3 hillocks from the second branchial arch, and they form the rest of it. The inner folds like the antihelix, the antitragus, and finally the earlobe. It's just brilliant modular design, but when these hillocks don't fuse perfectly, it can result in pretty common findings, like little preauricular pits or tags.
So you can see where this is going. When this fusion process goes wrong in a more significant way, it results in microtia. That's a condition where the outer ear is really small, malformed, or in some cases completely absent. It's a direct consequence of a failure in this 6-piece assembly process.
And here's a quick clinical pearl, just for you watching at home. If you find these kinds of custom medical videos useful, please do us a favor and like and subscribe. It really helps us make more content just for you.
Okay, now moving on to the next segment. After seeing how things can go wrong on the outside, you might assume the whole system is probably compromised. But that's where the story gets really, really fascinating, and it's a detail that can change a patient's entire prognosis. This right here is the key takeaway of this whole thing. There's a complete separation between the outer ear's blueprint and the inner ear's blueprint. Just because the external structure has a flaw, it tells you almost nothing about the state of the delicate machinery deep inside.
And here's why. They are 2 totally separate construction projects. The outer ear develops from that branchial apparatus we talked about, the same stuff that forms the jaw. But the inner ear, where the cochlea is, that develops from a completely different patch of tissue called the otic placode. They literally follow different plans on totally different schedules. This fundamental fact of embryology is exactly why a child can be born with severe outer ear malformations, the things we can see on the outside, but possess perfectly normal hearing structures deep inside. The blueprints are entirely independent of one another. So, we're going to end with this thought. A visual inspection of the ear. It only tells you about one of two independent construction projects. It reveals the story of the Pinna and the Canal for sure. But the real story of hearing? Well, that often lies much, much deeper.
Welcome! In this explainer, we're going to map out the ear's developmental blueprint, and we'll get started today with one of anatomy's most elegant puzzles, the really fascinating origin story of the middle ear bones. Okay, so let's just dive right into this, because it's a fantastic question. I mean, if you look at the malleus, incus, and stapes in an adult, they work together as this single, seamless chain. So why on earth would they have a dual nerve supply? Well, the answer isn't in their final form. You actually have to go all the way back to how they're born. So here's our game plan. We're going to start with the puzzle itself. Then we'll look at the two different developmental territories that actually build the bonds. After that, we'll see where the space they live in comes from. And then finally, and this is the cool part, we'll connect all of it to real-world clinical medicine. To solve this, you really only need one fundamental rule, and it's this. A structure's nerve supply is like a permanent, indelible record of where it came from embryologically. You see, the nerves get packaged with their structures super early on, and they just stay with them for life. Okay, let's begin with our first critical building block, the first branchial arch. You might also know it as the mandibular arch. So what's so fascinating here is the company these structures keep. I mean, look at this list. The head of the malleus and the body of the incus, they develop from the exact same block of tissue as your chewy muscles. And because they all grow together, they share the same nerve supply, the trigeminal nerve. Now for the second arch. And you gotta think of this as a completely separate developmental package. It's responsible for a whole different set of structures. And yep, it comes with its own nerve pre-installed. And this just brilliantly illustrates the other half of our puzzle, right? The entire stapes and its tiny little muscle, the stapedius, develop right alongside the muscles that control your facial expressions. And, true to our rule, they are all supplied by the facial nerve. So the crucial point is this. The ossicular chain isn't one piece. It's a hybrid. It's kind of like it was assembled from two totally distinct kits. The first kit gives us the malleus head and the incus body. The second kit provides the malleus handle, the incus long process, and the entire stapes. And, most importantly, each kit comes with its own nerve. Okay, so we've built the bones, we've got the hardware, but what about the air-filled room they actually live in? Well, that comes from a completely different source material altogether. Meet the first pharyngeal pouch. You can think of it as an internal balloon made of endoderm. That's the same stuff that lines your gut. It starts deep inside the embryo and expands outward, forming the eustachian tube and then that middle ear space, wrapping itself around the ossicles, which, remember, formed totally separately. And this is why the lining of your middle ear can produce mucus and has these tiny little hairs, cilia, to clear it away. It's fundamentally a respiratory-type lining. This directly explains why middle ear infections can lead to that nasty fluid buildup, you know, what's commonly called glue ear. It's just the mucosa doing what it was designed to do, but in the wrong circumstances. And hey, just a quick thought on how explainers like this get made. The content is always what's most important, but if you're finding this breakdown useful, things like liking and subscribing really do help us keep creating them just for you. Okay, with that said, let's get to the real clinical payoff and see why all of this embryology is so critical. This is where all that complex embryology goes from being just academic to being absolutely essential in the clinic. Knowing where all these different parts came from allows clinicians to predict exactly what to look for in congenital malformations. This table just makes it incredibly clear. Take a condition like Treacher-Collins syndrome, right? It primarily affects the first arch, so you'd expect to find problems with the malleus head and the incus body, while the stapes is often totally spared. Now, conversely, if a syndrome affects the second arch, you go looking for a malformed stapes. And because the facial nerve is part of that developmental package, you also anticipate an abnormal course of that nerve nearby. And that quote really just says it all. This one developmental concept is basically the master key. It unlocks our ability to diagnose and understand these incredibly complex conditions, and it turns what looks like a confusing collection of symptoms into a predictable pattern. It's anatomy telling a story. So, there we have it. We've solved our puzzle, but the real takeaway here is the method. This embryological way of thinking, you know, tracing structures all the way back to their origins to understand their final form and function. It doesn't just apply to the ear. It is an incredibly powerful tool for unraveling anatomical mysteries throughout the entire body.